All right, let's go ahead and get started. Thank you everyone for joining us. We're very excited to host the first session of the Transnational Interventional Radiology Journal Club. This is a really exciting initiative that we have going here. We have 13 institutions currently involved, and it's open access, so anyone is free to join. We're hoping to rotate between which institutions are co-hosting each session. So this is more of a decentralized kind of opportunity. This meeting will be recorded, just so everyone is aware. And we will be focusing on the pharmacomechanical catheter-directed thrombolysis for deep vein thrombosis paper, which presents the findings of the ATTRACT trial. We'll also be talking about a secondary analysis done by Comerota et al., which highlights some important features of the paper that weren't originally covered. My name is Austin Shinagawa. I'm a MS4 student at the University of Nevada, Reno School of Medicine. My co-host is Ricardo Martinez Garcia from Pitt Med. And we are joined with a very special guest, Dr. Shantanu Warhadpande. He is the lead author of the Pocketbook of Clinical IR and a PGY5 ESIR resident at Pitt. And he will be doing his IR fellowship next year at MCW. And with that, let's get started. So the agenda for today's meeting is first a discussion on venous thromboembolic disease and deep vein thrombosis. We'll be talking about the conventional management of DVTs and then briefly discussing catheter-directed thrombolysis. And then we'll move into discussion of the two articles and end with a Q&A session with Dr. Warhadpande. So starting off with venous thromboembolic disease, can everyone see the PE here? And if you can't, there it is right there. So venous thromboembolic disease encompasses both DVT and PE. It's the third leading cause of cardiovascular death. Does anyone know the first two causes?
MI?
Oh, yeah.
Good. Yeah, I think I heard both. So MI and stroke. And annually, there are 900,000 cases of lower extremity DVT, causing 600,000 cases of PE and 50,000 deaths per year due to VTE. A third of patients with VTE will have recurrence within 10 years, and half of patients will develop long-term complications, which we will be talking about later. So starting off with Virchow's triad for thrombosis, can anyone name the three components or one of the three?
Turbulence, hypercoagulability, and
Stasis.
stasis.
Perfect. All right, so yeah, venous stasis, endothelial injury, and hypocoagulability. You can classify some of the risk factors into these three criteria. So for example, with venous stasis can be caused by external compression, narrowing of the lumen if there's some scarring, foreign bodies, and even if the patient is immobilized. Endothelial injury can be caused by things like a prior DVT, prior trauma, or even toxic infusions like chemical or chemotherapy and TPN. And hypocoagulability can be caused by things like OCPs, pregnancy and the postpartum period, malignancy, genetic thrombophilias, and smoking, which is a very important risk factor. So moving on to venous anatomy, which is actually very important for this paper. To start with, there are superficial and then deep venous systems of the lower extremities. The superficial is mainly composed of the lesser and greater saphenous veins, and then the deep venous system is the femoral vein going to the popliteal and then to the tibial and fibular veins. The lower part of the deep venous system, actually the entire deep venous system, mirrors the arterial system. And then going up, the common femoral veins empty into the external iliacs, which empty into the common iliacs, which empty into the inferior vena cava, and then the right heart and pulmonary arteries. So you can see how clots from the veins can travel upwards into the lungs. And as you see here on the left is the deep venous system, and then the supravenous venous system on the right. These are pictures taken from the IR playbook by Nikki Keefe, which is an excellent resource. And then you can also distinguish DVTs by proximal and distal in the lower extremity. So proximal are DVTs in the popliteal, femoral, and iliac veins, and then isolated distal are DVTs which have no proximal component and are confined to the calf veins, so anterior tibial, posterior tibial, peroneal, and muscular veins.
Austin, are you able to get to the picture of the venous system again one more time?
Yes. This one right here?
Yep, perfect. I'll make one quick comment on this. One thing that I did not know as a med student that became a very important part of learning venous pathology was the interaction between the superficial and deep venous systems. So you have these perforating veins. I don't know if there's a way we can show them a picture, or if you want to look it up on your own time, that's fine too. But the perforating veins are extremely important in understanding how the superficial and deep venous systems interact. So you have these veins, and they're usually named veins, like the Dodd perforator and so on, that are in discrete areas in all of us that connect the superficial and deep. And and Austin, I apologize if you cover this later on in the slideshow, but the perforators become very, very important when you're dealing with superficial venous insufficiency. And that's something that will come up over and over again when you're in venous clinic, vein clinic. You'll notice that the ultrasound techs, in addition to interrogating each of the superficial and deep veins, they will also try to find the perforator and see if there's reflux in them. So the blood usually goes from the superficial and into the deep via the perforators. So a lot of times, if the perforator is not doing its job, then you start getting superficial venous insufficiency. So that's just a quick aside. Like I said, I hope do you cover this later, or is that
No, we don't. So thank you for bringing it up.
Perfect. Yeah, and it's nice to take a look at it. There's not that many perforators, so it's good to kind of just take a look at them to familiarize yourself as to where they are and sort of what their function is. So continue. Sorry about that.
No, thank you very much. All right, so we're going to talk about deep venous thrombosis specifically now, not just VT as a whole. So can anyone tell me a little bit, so the clinical presentation of DVT is mainly non-specific symptoms, pain, which you can elicit with the Hohmann sign, which is basically flexing the ankle and seeing if that elicits pain, dorsiflexion. You can also get erythema in the leg, warmth and swelling. And you can differentiate these patients, give them a pretest probability. And does anyone know the criteria that we give? I showed it briefly on the slide here. And so the criteria is the Wells score for DVT. Here is an example of the Wells score. And this is a good way, a validated way to distinguish patients into different categories. And these categories, being helping you to determine what their actual risk of DVT is based on clinical characteristics. And so before we talk about the diagnostic tree, I wanted to talk about D-dimer a little bit. So D-dimer is a degradation product of cross-link fibrin clot. The D-dimer testing assay that we use is sensitive, but it's not specific. And so basically what this means is D-dimer can help to rule out DVT, but it should not be used as an isolated diagnostic test. And that we need to interpret these findings in the context of pretest probability determined by things like the Wells score or other diagnostic testing. And you can see here on the left exactly what D-dimer is. Plasmin breaks down the fibrin mesh into D-dimer and then other fibrin degradation products. D-dimer less than 500, it's typically considered negative, whereas positive is over 500. And then there's also high sensitivity and low or moderate sensitivity assays, which we'll talk about when we discuss the diagnostic tree.
Just a quick aside about D-dimer. There's a lot of institutions are actually using D-dimer in COVID patients. And the way they're using them is because COVID is, a lot of these patients are high risk for DVT-PE. The way they're using it is to get a baseline D-dimer level, knowing that it's probably going to be elevated given the systemic issues going on with the patient. And then you can trend it, or if you can get a later value, if it's higher, and then you can sort of use that as a way to kind of guide your clinical concern for whether or not there's a DVT. So get a baseline and then use that and compare that to a later D-dimer level. So just a quick aside.
It's very interesting. Thank you for bringing that up. And so another diagnostic modality we can use is compression ultrasound. This is the initial imaging modality of choice for DVT, and it's highly sensitive for femoral popliteal DVT or proximal DVT and less sensitive for more distal ones. The diagnostic criteria for imaging thrombus on ultrasound is non-compressibility, and this is typically done around 2 centimeter intervals up and down the vein. An absent signal on Doppler ultrasound, absent respiratory phasicity, which is movement or expansion of the vein with respiratory cycles, as well as augmentation, which is compression of the vein at a more distal spot and then seeing if the vein size changes. You can also sometimes see an actual visible thrombus on ultrasound, which can be hypoechogenic or hypogenic or hyperechogenic. And here are some videos of, let's see if we can get these working. It looks like we won't be able to, but this is just a video of a normal vein, and then you can kind of see the clot here in the femoral vein. So compression ultrasound can be performed at the bedside as POCUS or point of care ultrasound. You can also distinguish whether there's acute or chronic clot based on certain characteristics like echogenicity, lumen size, and presence of collaterals. You can also do different types of ultrasound. So you can do proximal or whole leg. Proximal detects what can be called the clinically significant femoral popliteal DVT, whereas whole leg will be able to detect isolated distal DVT in the calf. However, whole leg compression ultrasound is more difficult to obtain and interpret, and so some institutions might just do proximal, but this can vary depending on where you're at. An alternative to compression ultrasound is CT or MR venography. And this is useful for even more proximal DVTs like iliocaval. And then you can also just do direct venography by going in the vein. And so here's a basic diagnostic algorithm for a first suspected DVT. There's a lot of information on this slide here, but the main point is that you can start with a pretest probability, something like the Wells score, determine whether they're low, moderate, or high risk, and from there, work down the diagnostic tree. You can see if there's a low pretest probability, you can get a D-dimer, and if the D-dimer is negative, you can basically rule out that patient for DVT. Or if you get an ultrasound and it's positive, you treat that patient. A lot of the complexity in this is based off the difference between whole leg ultrasound and proximal compression ultrasound. And so I would take the time outside of this presentation to kind of go down this tree and think about some of the differences. And you can see here for the whole leg ultrasound, if there's negative, you can actually usually rule out DVT. And if it's positive, you can do serial ultrasounds down the road, or you can also do move to a proximal compression ultrasound, but we'll talk a little bit about this later as well. To answer a question, the Hohmann sign is not routinely used to screen for DVT. it's, from what I hear, it's not sensitive or very specific either. It's just kind of like an adjunctive finding that, you know, if you find it, it's interesting, but its actual clinical use is pretty low. So in terms of complications of DVT, the reason we want to distinguish between proximal and distal is because proximal DVTs confer a higher risk of complications. And these complications include extension of the clot or recurrence, pieces of the clot breaking off and going to the lungs and causing pulmonary embolism, phlegmasia, which is basically a massive occlusion, and there's two types, phlegmasia albidolens, where the leg is pale. This is due to transient arterial spasm, and about half of these will progress to phlegmasia ceruleus dolens, where the leg is cyanotic and blue. This occurs when you get superficial vein compromise in addition to deep venous compromise. Severe venous hypertension actually can restrict arterial flow, causing ischemia, which can actually progress to gangrene and can be limb-threatening. And so if you see this in a patient with a DVT, you need to act fast. So another really important complication is post-thrombotic syndrome. You can get damaged venous valves from the DVT, as you can see here, and that leads to pooling of blood in the extremity. It's a form of secondary venous insufficiency as opposed to primary, where the cause is not really known. Proximal DVTs are at higher risk of developing PTS, and actually nearly half of these go on to develop PTS. The symptoms of PTS include pain, swelling, heaviness, fatigue, and you can even get pigmentation with deposition of hemosiderosin. And you can also get venous ulceration at the medial malleolus if it is severe. PTS is a clinical diagnosis that you typically want to diagnose at least 3 months after an acute DVT, so you're not overlapping the symptoms of acute DVT with PTS. These patients have a poor quality of life. The symptoms can become very severe, and the management we have right now is conservative for the most part. So things like compression stockings, leg elevation, and exercise. There are some endovascular techniques that can alleviate but not cure PTS symptoms. So the real key for PTS is prevention.
This is super important. I think this is something that before you delve into the treatment and sort of how to manage DVTs, this is probably one of the most important slides, just because from an interventional radiology perspective, especially when you start talking about the ATTRACT trial, which Ricardo will do, knowing this entity is going to be very important, because this is what we're trying to prevent when we treat patients with iliocaval DVTs and so on. So make sure you know this. And one thing that I'll say is that both for PE, for DVT and PE is one spectrum, right? It's clot from the veins going up to the lungs. And for both of them, they cause acute problems. In the case of DVT, you're going to get pooling, you're going to get pain, and then you have chronic problems that happen down the line. So for both DVT and PE, you have acute problems and chronic problems, and this is a chronic problem for DVT. Does anyone know what the chronic problem for PEs is? That's
Atelectasis?
So no, it's a good guess. It's called CTEPH. Have you heard of that? CTEPH. It's chronic thromboembolic pulmonary hypertension.
Okay.
Have you all heard? Anyone heard of that? So just to give you a quick primer, and I don't want to interrupt again too much, so I apologize if I'm talking too much here. But so CTEPH happens when you have a clot in the lungs, in one of the pulmonary artery branches, which eventually a lot of the clots that happen in the lungs, that go to the lungs, get reabsorbed by the body. 10% and 15% of the time, usually they don't get reabsorbed and they stick around. And in that situation, you essentially get blood flow to that particular part of the lungs being compromised, and this eventually leads to pulmonary hypertension. So it's a reason that patients get pulmonary hypertension. So that is the chronic pathology that results from PEs. It doesn't happen in all patients, but when it does, obviously it's a huge issue for that patient. Yeah, and Dr. Vedantham has put some good information in the chat as well, if you guys want to refer to that.
Thank you for your input. And definitely feel free to jump in at any time. We really appreciate it. All right, so the way we kind of stratify the severity of PTS is with the Villalta score. As you can see on the left, it's composed of 5 symptoms and then 6 clinical signs. You break these down into whether the symptoms are present, and if they are present, if they're mild, moderate, or severe. In terms of score interpretation, less than 5 indicates no PTS, and then 5 up to 15 indicates the severity of PTS. A good point to know is that if a venous ulcer is present, it's automatically severe PTS. All right, so we're going to talk a little bit about conventional management of DVT. And so there's 4 main treatment goals, which were covered in the IR pocketbook, actually, or Pocketbook of IR. So these are symptomatic relief in the acute stage, preventing recurrent DVTs, preventing acute PEs, and then preventing PTS. And so the really mainstay of conventional management is anticoagulation. And so you can see here, we have our vitamin K antagonists, warfarin, direct factor 10A inhibitors, such as apixaban, rivaroxaban, edoxaban, direct thrombin inhibitors, such as dabigatran and argatroban, and then antithrombin 3 stimulators. So if you remember, heparin stimulates antithrombin 3 to inhibit factor 10A and 2A, and then low molecular weight heparin, such as Lovenox and Fondaparinux, inhibit 10A alone. So in terms of initial anticoagulation, meaning the first 10 days, you want to consider, whether you're going to treat these patients inpatient or outpatient. Some factors that might push you more towards inpatient management are if they have a massive DVT, a symptomatic PE, if they're at high bleeding risk, if they have comorbid conditions that are making them sick, and also if they have renal insufficiency, in which case you want to avoid Lovenox, which is what is typically used when you're treating them outpatient. Some treatment options are Lovenox bridge to warfarin, dabigatran, or edoxaban. Just starting off with factor 10As where you don't need a Lovenox bridge. And then also you can use a heparin drip if they are inpatient. Another important thing to consider is the Warfosa trial, which showed a benefit of using aspirin 100 milligrams daily after anticoagulation indefinitely, actually. One way you can stratify patients in terms of bleeding risk is with the Hasbled score. And this is for patients on anticoagulation in atrial fibrillation. It's important to know that it's not actually validated for VTE, but it might help guide you clinically. Also, if you're using especially unfractionated heparin, watch out for HIT, which is heparin-induced thrombocytopenia. If you see your patient's platelets dropping, or if they're developing thrombus somewhere else, something to consider. So in terms of long-term anticoagulation guidelines, for not cancer-associated, the first line recommended. Oh, and by the way, so these are the guidelines developed by CHEST, which is the American College of Chest Physicians. For not cancer-associated, the first line are the DOACs, the direct 10A and thrombin inhibitors. And then they recommend as a second line to use warfarin instead of Lovenox. For patients who do have cancer or are pregnant, does anyone know the drug that is preferred? So the one that you want to use if someone has cancer, if they're pregnant, is actually Lovenox. And this is really important to know. So in terms of duration of therapy, the standard is 3 months of anticoagulation. But this is kind of a minimum. We don't really know the optimal length of time, but you might want to consider 6 to 12 months if there's more risk factors, such as if it was unprovoked. And you also want to consider indefinite coagulation if it's an unprovoked proximal DVT or if it's their second unprovoked DVT. You also want to consider it if there's a provoked DVT with irreversible persistent or multiple risk factors. And one of the big ones here is something like metastatic cancer, which the patient will likely have for the rest of their life. And so you're going to want to anticoagulate them for the rest of their life, as long as they don't have contraindications to anticoagulation, which we'll discuss in a little bit. For isolated distal DVTs, these are kind of a different beast. You want to anticoagulate if they're symptomatic or asymptomatic with risk factors for proximal extension. And some of these are on the bottom here. If they have neither of these, you can opt for surveillance with serial proximal compression ultrasounds weekly for 2 weeks. If the thrombus does not extend for these 2 weeks, you can opt for no anticoagulation. And if it extends proximately, you can anticoagulate. For recurrent DVTs, you want to evaluate the patient's adherence to their medications, and you can do this with an INR for warfarin, or ask the patient for other drugs where you can't measure their adherence. You want to make sure that this is an actual recurrence of DVT and not just extenuation of the DVT they had before. And then you also want to consider an underlying malignancy. If they keep having DVTs, they might be hypocoagulable because of cancer. If they're on a warfarin or a direct 10A or thrombin inhibitor, what's recommended is a temporary switch to Lovenox. And if they're on long-term Lovenox already, increasing the dose of Lovenox. I also wanted to talk briefly about thrombophilias, which are inherited thrombotic disorders. The 5 main ones to know are antithrombin 3 deficiency, protein CNS deficiency, factor V Leiden, and then prothrombin G20210A, which is a specific mutation, and then other thrombogenic conditions such as antiphospholipid syndrome and malignancy. Which patients do you work up for these? Well, you don't actually want to work up all patients with unprovoked DVT. Good patients to work up that there's an actual benefit are first-degree relatives with documented venous thromboembolic disease, patients at a young age who are less than 45 years old, patients with recurrent thrombosis, if they have a thrombosis in an unusual vascular bed, such as hepatic or portal veins. And then you can also do a limited workup for malignancy in a patient presenting with a first-time unprovoked DVT. You can also work up a patient for protein C deficiency if they have warfarin-induced skin necrosis, but that's just kind of a side point. I do want to mention that working up patients for thrombophilia doesn't really have an effect on their clinical outcome, but it can be useful for them to know, to tell them, things like avoid smoking because you're at very high risk, or also for genetic purposes. So moving on to interventional management, we're going to talk about catheter-directed thrombolysis and then IVC filters. So catheter-directed thrombolysis is based off the theory that you want to open up the veins because anticoagulation prevents clot extension, but it doesn't actually recanalize the vessel. Whereas thrombolytics, such as TPA, which we'll talk about in more detail, actually break down the clot and can open up the vessels. Catheter-directed thrombolysis in particular is an intervention where you put a catheter in direct apposition to the clot to deliver very targeted therapy. And you can use smaller doses than you were if you were using systemic TPA, which is one of the big advantages. The alternative to catheter-directed thrombolysis is actual surgical thrombectomy, where they open up the veins and take the clot out that way. You can see here in the picture an interesting example of May-Thurner syndrome, which is a compression of the left iliac vein by the right common iliac artery, and this predisposes patients to clots in their left iliac veins or left venous system. So a brief refresher on TPA. So TPA converts plasminogen to plasmin, and plasmin breaks down fibrin into fibrin degradation products and D-dimer, including D-dimer. The major complication of TPA administration is bleeding, and so it's really important to know the contraindications to TPA. And so these are pretty absolute contraindications here. And it's important to know these because they also apply to catheter-directed thrombolysis. Even though you're using lower doses, the risk is still present. And so the contraindications include head trauma or stroke in the past 3 months, a history of intracerebral hemorrhage, a current intracerebral hemorrhage, subarachnoid hemorrhage, or a large multilobar infarct, recent head or spine surgery, a cerebral aneurysm, intracranial neoplasm, or AVM. An interesting point on that is that you can screen patients who have a history of cancer that tends to metastasize to the brain and cause hemorrhagic infarct. So things like renal cell carcinoma, HCC, et cetera. Also, if they have an elevated blood pressure, specifically systolic over 185 or diastolic over 110, active internal bleeding such as GI bleed or acute bleeding diathesis. So very important to learn these, not just for catheter-directed thrombolysis, but also for things like stroke. So what are the indications for CTT then? So phlegmasia, where the patient needs acute recanalization. As we said earlier, anticoagulants prevent clot extension, but they don't open up the vein. In phlegmasia, you need to open up the vein immediately. Also, if they have lifestyle limiting acute DVT symptoms that aren't resolving with anticoagulation alone. However, per the CHEST guidelines, they don't recommend doing CDT for acute proximal DVT without the above indications. However, iliofemoral and cable DVT is at the highest risk of developing severe PTS. And then the CAVENT trial in 2016 found a 28% absolute risk reduction with CDT for a first-time iliofemoral, 28% absolute risk reduction in PTS for first-time iliofemoral DVT with the use of CDT. And so that kind of sets us up, sets the stage for the ATTRACT trial, which Ricardo will be covering later. And on the left here is a picture of a proximal clot. You can see a balloon venoplasty and then some recanalization of flow here. So the most common complication of CDT is a major bleed, and that's why it has the same contraindications as TPA. You can also get a symptomatic pulmonary embolism just due to manipulation of the thrombus when you're sticking wires and catheters through it. You can avoid symptomatic PE by periprocedural therapeutic heparin, and then you monitor them routinely with a PTT or an ACT. You can also consider a pre-procedural IVC filter placement if they're at high risk and they have poor cardiopulmonary reserve. And that means if they did have a PE, it could be catastrophic, and those are the patients in which you might want to consider IVC filter. You can also get compartment syndrome if they have something like phlegmasia, where there's already some tissue death, but this is less rare. So in terms of procedural details for CDT, you achieve venous access based on the distal extent of the thrombosis. So you can access the common femoral, the popliteal, or even the posterior tibial vein. It's typically recommended to use ultrasound guidance due to the high bleeding risk of arterial puncture when you're using thrombolytics. You can cross the occlusion with a catheter and guide wire, and then venography to confirm you're past the clot and intraluminal. Then you can insert a multi-side hole infusion catheter across the occlusion, and then administer TPA slowly through that catheter. 1 to 2 milligrams or 0.01 milligrams per kilogram per hour is the standard dose, and then you can divide that if you're using multiple catheters. So if you're putting catheters in both legs, you would just take the standard dose and then divide it by 2. Subtherapeutic heparin can also be infused through the sheath to prevent clot formation on the catheter itself. But you don't want to use therapeutic heparin because that increases the risk of bleeding. Here's a picture from the IR playbook showing another example of a DVT that's recanalized after a CDT procedure. In terms of initial post-procedure care, you want to admit these patients to the ICU for close monitoring. Anytime you put a patient on TPA, they should probably be in the ICU. And then you want to serially measure hemoglobin, platelet counts, and fibrinogen. Monitor for complications such as bleeding, PE, and compartment syndrome. And you want to check for bleeding also at the access site, not just internally. Repeat venography at 4 to 24 hours post-procedure. And then if you find significant residual thrombus is present, you can perform mechanical thrombectomy or additional infusion. Some options for mechanical thrombectomy include maceration with balloon balloon catheter, aspiration, rheolytic hydrolysis, which is, I recommend you look up on your own time. It's a very interesting way of mechanical thrombectomy. And then you can also do something like a clot retriever with something like the Inari device. Pharmacomechanical thrombectomy is a combination of these two techniques of mechanical and catheter-directed thrombolytics. And then you can actually perform mechanical thrombectomy initially when you're doing the thrombolytics, and that's something that's kind of talked about later on in the ATTRACT trial paper. Also, if stenosis is present, so for example, something like May-Thurner syndrome, which we discussed earlier, you can put a stent in, and this can reduce the risk of future clots. And then briefly glancing at inferior vena cava filters, these are filters placed in the IVC, usually infrarenal, and usually we want to place retrievable filters that will catch clots traveling back to the lungs to prevent PE. The major contraindications for anticoagulation include active hemorrhage, low platelet count or other diathesis, high bleeding risk surgery or procedure either recently or planned in the future, and then acute or prior intracerebral hemorrhage. And the reason I am going over these is because the indications for IVC filters are acute proximal DVT and a contraindication to anticoagulation. If they're having recurrent PEs despite being on an adequate anticoagulation regimen, or if they have a poor cardiopulmonary reserve, and the morbidity from a PE would be extremely high. This is just a very brief overview of IVC filters. It's a whole nother can of worms to go into the literature regarding these, so I won't do that out of the scope of this presentation, but we can maybe cover it in a future journal club, actually. So thank you for listening to that clinical context. Feel free to reach out to me at my email if you have any further questions, or you know someone else who's interested in joining. These are the references I used, and now we'll move on to Ricardo for the ATTRACT trial. Before I close, are there any questions or any more input?
Austin, I thought that was a really good overview. I think you covered pretty much all the major points. You know, I think this is something we see all the time in both IR and general medicine. So I think one of the reasons why a lot of the interventionalists out there like venous disease is because it's such a good interplay between obviously the procedures that you discussed, but also because of how much clinical knowledge is required. So you get to really flex your clinical skills. So with that, obviously you need to know what you're talking about. So Dr. Vatican-Cherry has been posting a lot of the studies in the chat. The reason, and this is something I kind of learned from Dr. Vatican-Cherry, which was that it's one thing to know a fact, and that happens a lot in medicine, where you sort of just, people will hand down knowledge to you, and you kind of just take it as gospel. But it's the studies that really kind of drive the clinical decision making, right? So knowing the studies is incredibly important, because when you're an interventionalist talking to a hematologist or a surgeon, you need to back up whatever you say with studies. So a lot of the studies that Dr. Vatican-Cherry has posted on the chat are super important. And you know, I think get in the habit of questioning why something is done the way it is, and looking at the studies. And especially for the junior med students, I think this is a habit that I unfortunately did not really get into until the end of med school, and even into residency. So the earlier you start, the faster you're kind of just, it becomes second nature after a while. So take a look at the studies he's mentioned. But yeah, Austin, this was a phenomenal overview.
Thank you very much. And that is part of the reason that we wanted to host this journal club, is so as students, we can start learning the evidence, so we're more prepared when we become clinicians. Thank you very much for all your input, Dr. Warhadpande, and I will move on to let Ricardo present now.
All righty, thank you so much, Austin. I'm just gonna go ahead and share my screen here really quickly. Just give me 1 second. Okay. Cool. All right, so can everyone see my screen well? All right, not blurry at all?
Looks good.
Okay, good. All righty. So I just wanted to first introduce myself. My name is Ricardo Martinez. I'm a third-year medical student here at the University of Pittsburgh. And I'm also one of the interest group coordinators for the IRDR interest group here at Pitt. So I just wanted to kind of preface the whole session and just want to let everyone know that it is a pretty stress-free environment that we want to kind of conduct here. I'm going to be going into the trial, and the format will be just a set of questions, which I think we already sent out through email, and anyone can kind of chime in and just answer the questions, give any opinions that they have about the results or any experiences that they've had in the past. And so our objectives today are to just basically learn about the ATTRACT trial as it pertains to DVT management in everyday IR. And to also learn from the experts that we have here today, Dr. Warhadpande and Dr. Vedantham, and also to learn from each other. I know a lot of us are in different stages. And so without further ado, I'm just going to go ahead and get started. All right, so first question, just to kind of dive into it. If anyone knows kind of what the author's affiliations were by any chance, and it's okay if you don't, these are kind of just extraneous details, but
First author was at WashU in St. Louis.
Yeah.
I did notice that. Yeah.
Yeah. So here's just basically a list of them. There's a lot of institutions involved, and we're going to talk about this in a bit, but about 56 hospitals involved in this as well.
I kind of sprung that on you last minute, Ricardo, the change to the slide. So the reason I included this, if you can go back. Yeah. So the reason I included this is to show that there are a lot of academic institutions participating in this, and, it wasn't driven by industry necessarily. So, we can take the study a little more seriously.
Thank you, Austin. All righty. And so how the study was funded, and I'm also going to go ahead and actually move on to that slide. So Austin said it's just a list of funding here. And like Austin was saying, basically, we can definitely take the study seriously. There's been a lot of people involved in this, and it's one of the higher level evidences that we have for this type of treatment. Let's see. And so let's actually go ahead and dive into the study now. So can anyone kind of tell me what the clinical question was for the trial?
Let's think. Okay, if I were to break it up into PICO, and that patients, so I would say in people with DVTs, if we intervene with catheter-directed therapy compared to not the standard therapy with just anticoagulation or a combination of, then looking at their outcome, what would the change in outcome be in developing PTS?
Yeah, no, that's great. And I'll go into the details, but you basically covered everything. Anyone kind of want to also go into the study design and what was the reason behind using pharmacomechanical thrombolysis as opposed to other types of treatments?
I could keep going. It was someone else can jump in, but I'll just say it was a phase 3 multi-center randomized trial. They said it was open label as well, and the assessor was blinded.
Great. Yeah. So yeah, for patients, so like your name is again, sorry, I didn't get your name.
Oh, hi, my name's Adlai. I'm from Howard.
Nice. Adlai. So like Adlai says, this was basically a study looking at patients with proximal lower DVT, and also looking at basically the addition of pharmacomechanical catheter-directed thrombolysis plus anticoagulation and how that can possibly prevent PTS versus anticoagulation alone. Study design, like you said as well, multi-center randomized open label assessor blinded phase 3 control trial. And the rationale behind using pharmacomechanical Thrombolysis is basically just kind of getting into the open vein hypothesis, where there's been a lot of randomized trials that have suggested that opening up the vein and kind of taking the thrombus out can actually decrease venous hypertension and reflux of blood into the distal part of the vein, and can actually decrease the possible symptoms associated with PTS. All right, so next question. So who was included in the study population, and what were kind of some of the exclusion criteria? And there's a whole list of them, so you can go ahead and just kind of touch up on a few if you like. And if not, I can go ahead and keep going as well.
I mean, people can't, let's see. Well, we were including people with proximal DVTs.
Right.
Right. And then someone else can chime in about the exclusion criteria. There's so much.
Yeah, there's a lot. So yeah, basically patients across 56 clinical centers in the US from 2009 to 2014 with symptomatic proximal DVT involving femoral, common femoral, or iliac vein. And patients were actually stratified into the most proximal extent of the DVT, so iliofemoral versus femoral popliteal. And for the exclusion criteria, there's the whole list of them, but here's just a couple, and I highlighted some that I found, at least myself, to be pretty important and that Austin kind of went through. And a lot of these were actually contraindications to both CDT and TPA. And so just to kind of highlight these. So interventions.
I had a question.
Yeah.
Why was could you go back to the exclusion criteria? Something with the symptoms lasting over 14 days, why would those people be excluded? And what symptoms were they talking? Do you remember, do you know?
Yeah, let's see. Yeah. So you're talking about, yeah, go ahead.
Yeah, so very good question. So when you have symptoms greater than 14 days, this is kind of the benchmark for when the clot starts to organize and become, harder to remove or affect interventionally.
Gotcha.
All right, thank you.
Also, sorry, before you move on, we're going through all these questions, but why is any of this important? Like, why do we care about what the study sample was?
For applicability of the findings?
Exactly. The external validity of the study, right? We have to think about when we're using these trials to justify treatment in specific populations, we have to make sure the study actually applies to those populations. Okay, great, thanks.
Yeah. All right, and just some of the interventions. So we can also just let anyone, if anyone would like to kind of discuss what the interventions were, and also what were the goals of the physicians using these interventions? What were the goals of the treatment that we were trying to accomplish? All right. So the first one, so the interventions: pharmacomechanical catheter-directed thrombolysis plus anticoagulation, like Austin discussed before, and that would be compared to anticoagulation alone, which would be the control group. And the goals of the treatment, I can go ahead and pull up this as well, and I'll talk about this in a second, but the goals of the treatment was to basically remove greater than 90% of the thrombus and to restore blood flow. And so to just kind of go through what they did, specifically looking at the TPA delivery. And so about less than 35 milligrams of TPA were delivered via many different ways, including multi-site hole catheter, and then also single session thrombus removal using the angiojet rheolytic system, which Austin also mentioned in the previous presentation, the trellis peripheral infusion system. And then following that TPA delivery, physicians could actually do the mechanical part of the removal of the thrombus through many different ways as well, including balloon maceration, catheter aspiration, balloon venoplasty as well. And so balloon stenting as well was actually recommended in patients that had greater than 50% narrowing or had any robust collaterals. and a mean gradient pressure above 2 millimeters mercury. So one of the things that I also thought about while reading this article was why do we think that they were recommending stenting in robust collaterals? And there's no like right or wrong answer. This is just kind of like a question that I came up with as I was reading through the article here.
Maybe to encourage blood flow so we don't have as much stasis.
And so one of the things that I think, I believe the authors talked about, which is basically robust collaterals were just a way to tell whether there was not enough blood flow going through. And so the venous blood flow had to get through in other ways. And so one of the main reasons for that, for using stenting, was the robust collaterals, because that could actually tell you how much of narrowing there was in the vein. And also the physicians could actually use a combination of any of the above as well, which we'll go into in a bit. And so what were the time intervals for short and long-term follow-up, the primary outcomes, and the clinical significance of the primary outcomes?
From what I remember, there was 0, 6, 12, 18, 24 for different follow-up time points. They were looking at, anyone else can say stuff.
No, that's all right. Yeah, so like you said, it's a short-term 10 and 30 days for some outcomes that I'll discuss in a bit, and long-term 6, 12, 18, and 24 months. And then the primary outcomes of the study were basically looking at the occurrence of PTS at any time between 6 to 24 months follow-up if the VIALTA was greater than 5, or if patients received any sort of unplanned procedure to treat any symptoms from the previous DVT, which could include like pain, difficulty ambulating, and ulcers, which were some of the bigger ones as well. And the clinical significance, so PTS, like Austin also mentioned before, develops in about half of patients with proximal DVT within 2 years. And so this is definitely something that we have to consider when we're treating patients. And it can lead to a lot of pain, it can lead to a lot of swelling, and it can also lead to major disability in a lot of patients. And like I mentioned before, this is kind of where the open vein hypothesis comes into. Alrighty. And then what were the secondary outcomes, if anyone can go ahead and kind of talk about those, if you remember them from the trial?
Oh, the severity of the post-thrombotic syndrome. So when they were following them, they would measure how severe the PTS symptoms would be, since it seemed like a lot of people still developed it.
Yeah, that's great. Let's see. So yeah, basically we looked at the occurrence of PTS at 6, 12, 18, 24 months. And then also the moderate or severe PTS like you were discussing, which is a VIALTA score above 10. And then some of the outcomes that they looked at, which they called the efficacy outcomes, included the recurrent VTEs, major bleeding, both early and overall major bleeding, and also death within 10 days and over 24 months. So yeah, and then these are some of the other outcomes that they looked at as well. The venous clinical severity score, and then basically looking at outcomes in terms of quality of life as well, using the SF-36 and the venous, and also pain severity and cap circumference as well. And so those are some of the ones that also carry the 10 and 30-day follow-up as well, like I discussed before. All right. Let's see. And so I guess a question that we can ask here is, if you had to pick any of these outcomes to follow up with your patient after being treated for DVT, which ones do you think would be more valuable to your patient, or which ones would you consider being more valuable to you as a clinician to follow up on?
Quality of life. Oh, there's probably something that's more.
No, there's no, like I said, no right or wrong answer, just to kind of.
I'll just say quality of life. There's probably, it depends on the person.
Yeah,
Major
I
bleeding
think
is a big thing.
pain and quality of life would be, from the patient perspective, something that, you know, you would care about their perspective on.
I was thinking perhaps the cough circumference as well from the physician's perspective.
Yeah. Yeah, so these are all great points. So yeah, they looked at a lot of stuff here, and I think that's one of the things that I believe gave a lot of validity to the results of this trial. They looked at both objective outcomes and also how the patients were feeling after the procedures as well, and their quality of life overall. And they also talked about the major safety outcomes, which I believe I already went to in the previous slide. So just recurrent VTEs, major bleeding or death within 10 days, and up to 24 months. And as Austin and I were actually talking about before this, there's a lot of good lessons to learn from this, looking at the major safety outcomes, because a lot of times, at least from what we've learned from the IVC filter, issues that have occurred in the past, sometimes being too aggressive is not the greatest way of doing things. And so we have to kind of outweigh the benefits and the risks. And in a lot of these patients, using CDT was not indicated. And so that's just something that we have to consider, so it has to not kind of tank our progress here. So what assumptions were used in the power calculation? And how are the assumptions made? If anyone can just kind of remembers from reading from the trial.
They wanted to have enough people to have 80%. I think 80% is like an arbitrary power, and 0.05 is that arbitrary alpha that people set. But yeah, they wanted to have enough people to make sure they had power.
Yeah. So yeah, 30%. So one of the things that they looked at was 30% of patients would develop PTS, so that's one of their assumptions. And then a CDT would actually, or catheter-directed thrombolysis would actually reduce that to 20% of patients developing PTS, and about 10% would be lost to follow-up. And like you mentioned, for the p-values as well. So primary and safety outcomes had a p-value less than 0.05. And secondary outcomes less than 0.01. And so just to kind of talk about what they used in terms of their analysis, so can anyone kind of discuss what the intention to treat versus per protocol analysis were?
Does anyone know what intention to treat is?
You can, I think it's when you do the analysis, assuming that people remain in the cohorts that you randomize them to, or maybe that's per protocol analysis, because I think we have to take into account when some people switch over to the other arm, or if they fall off the arm, something like that.
Yeah. Yeah, so intention to treat, so patient groups based on initial randomization assignments, and the per protocol analysis, so patient groups with exclusions of anyone who went against protocol. And so another question that's not right, or there's no right or wrong answers to this, but more for my stats knowledgeable people here, which I'm not, would you have done any other types of analysis on this study, or how else would you have looked at the data? And maybe what were the pros and cons of using this intention to treat and per protocol analysis?
I mean, one thing that did stick out was just there were so many different ways of delivering the TPA, and I was wondering if they would have stratified according to their delivery of the TPA. I think that would have been something. Maybe it was too granular.
Yeah, I think that's actually something that we mentioned later in the presentation, and also the authors mentioned as well at one point. Yeah, that's great. Any other thoughts on that? All right, go ahead and move on here. Okay. All righty. So sample size, and you don't have to know the sample size here, but do you kind of remember from reading the trial if there were any differences in baseline characteristics between the treatment and control group? So total sample size was 691 patients. Pharmacomechanical arm had 336 and control arm had 355. And mostly the demographics and the Vedantham scores are pretty similar between both groups, but there were some things that changed that were different between the groups, particularly some of the pre-treatment things that were going on with each of the groups. So warfarin percentage, or the amount of warfarin in the PMT group was greater than the control group. Low molecular weight heparin was used more in the control group, and then patients were seen in the outpatient setting more for the control group as opposed to the PMT group. And then major surgery, hospitalizations, and previous ipsilateral DVT were more common in the control group as well. All right.
So since this journal club is for med students, and part of it is because we're trying to learn how to read literature, why do we look at whether the demographics vary between groups? So it's
Reduce bias?
exactly,
Or-
yeah. So we can get bias because these are potentially confounding factors, right? They might affect the results. So it's just an important thing.
Yeah. Okay. And so the more common mechanical thrombectomy methods used, so balloon venoplasty, maceration, rheolytic were the more common ones compared to the other ones, and the common types of stents here as well, the Austin, Smart, and Protege. And so this is more a question for Dr. Warhadpande and Dr. Vatican-Cherry to answer if they can, but which of these do you commonly use in your practice? And if you use multiple of these, which do you use in which setting? And which do you like to use? Don't know if they can hear me here. Yeah.
Can you hear me?
Yeah, I can hear you.
Yeah, so basically,
Take this one.
hello?
Yeah,
Can you hear me? Okay. So essentially, I kind of use, so these, if you look at the wall stents, kind of Algiloy, woven stent, and the Smart and Protege are nitinol stents, as is the Zilver and the Luminex and the Lifestar and Epic, right? Those are all nickel titanium alloy or nitinol stents. The Viabon is a covered stent graft. So it's a nitinol stent, but it's got a PTFE layer, all right? So the classic ones we primarily use are, that I use is primarily Proteges. I use a 14 millimeter by 6 or 8 centimeter long, so a longer segment for iliac venous stenosis. But now we have these dedicated venous stents called the Vici and Venova. One's by BD and the other one's by Boston Scientific. So those are now a little bit higher radial force. One's a little bit more open cell, the other closed cell. The Venova goes up to 20 millimeter diameter. The Vici goes up to 16 millimeter diameter. So now we have these kind of, they're a little bit longer, bit more compressive resistance. And so that's typically what people have been starting to use now, Venova and Vici. But yeah, I was using kind of Proteges or Smarts, 14 millimeter diameter, but basically a nitinol based stent, I wasn't using a lot of wall stents, but a lot of people do use the Algiloy wall stents, which can go up to 24 millimeter diameter. But in the iliac vein, they'll go up to maybe usually 16 millimeter diameter to do it. They use intravascular ultrasound or IVUS to really measure the diameter of the vein. So that's probably the most accurate way to look for compressive physiology or compressive anatomy or synechiae, and also to size your appropriate stenting and also land it where the narrowing is likely to be.
I'll make a quick point about just a general approach to IR tools and procedures for all the med students. There's a lot of lingo in IR. There's a lot of words, a lot of different types of technology that we use, and it can get overwhelming very quickly. So I think your goal right now is to just recognize your wall stent, protege, just kind of know of a self-expanding stent, things like that. I think that is the most important thing for you guys to learn right now. The most important thing you need to learn right now is the clinical stuff behind all of this.
Yeah, I agree. The clinical is the most important thing.
And
and
the tools and the lingo,
start,
that will come.
Yeah, start to hear the lingo, right? So basically self-expanding versus balloon expandable, covered stent versus uncovered stent, open cell versus closed cell. Broad terminology is helpful. But I agree, it's a valuable to first learn the clinical, that's number one, and how to talk to a patient and manage it and know the evidence behind it, and then start to acquire the kind of the technical component.
Great. All righty. Thank you for your input. So we can go ahead and dive into the results of the primary outcome here. So once again, can anyone kind of, if they remember, discuss some of the results of the primary outcome, just the gist of them?
I remember there's just no, all right, there, no difference.
You can go ahead. I was just put it out.
No, there was just no difference between, at least with the primary outcome between the two arms. There was some difference in some secondary outcomes.
Yeah. So between the 6 to 24 months, like you were saying, there was really no significant difference between the pharmacomechanical catheter-directed thrombolysis plus anticoagulation versus just anticoagulation alone. So yeah, that was the primary outcome that they were looking at. Here's just a reference for the table there. And then were there any significant results for the secondary outcomes that you guys saw? Oops.
I think they mentioned the severity of PTS was lower in the intervention group, but there were no changes in quality of life.
Yeah, basically. So moderate to severe PTS between intervention versus control was 18 versus 24%, which was significant. But there was no significant difference in PTS occurrence or the Vialta scores, VCSF scores, or any other of the secondary efficacy outcomes, which were measuring quality of life, like you mentioned. And so why do we think that there was a reduction, I guess, in the moderate to severe PTS in the intervention group versus the control group?
Perhaps the mechanical thromboembolic treatment was more effective at restoring venous valve function. I guess that would be the theory.
Yeah, so I think, that's a great point. One of the things that I think they mentioned in the article was just basically saying that PMCDT, or the pharmacomechanical catheter-directed thrombolysis, may actually reduce the severity because, let's see, it's like, oh, I got cut up here. Basically just kind of tracking back to the open vein hypothesis, they were just looking at the different physiologic factors that may lead to PTS versus the actual progression of PTS. And so they were just talking about how there may be differences in that. And so there needs to be more studying going on of the open vein hypothesis and how that applies to actually removing the thrombus. Let's see. All right.
I definitely think that the I was just going to say there's I definitely about the fact that the valve function is maintained. One of the reasons why you eventually get PTS is because the valve function is destroyed by the clot. So there are definitely a lot of people that think that if you can treat the acute DVT quickly, you might be able to prevent the valve dysfunction from occurring. So that's I think that's a big group of people definitely do think that.
Sorry, you kind of cut up there a bit. I can't hear you anymore.
No, I think what he was saying is that, you know, so what happens is valves are, when you're standing, those valves are, in a normal person are competent, and the calf is driving, it generates 50 millimeters of mercury pressure. And so it drives the pressure up. But if your valves aren't working and they're leaky, the blood just pools. And when you're standing, it's mass gravity height. It's a column of blood that has a certain amount of mass and is based on gravity. So when you're lying flat or your legs are up, it goes to the heart. But if not, it pools into your calf, your thigh, your interstitial edema increases, you get the hemocenter deposition, et cetera. So the valves are really important, and we don't have a good replacement for valves yet. So it is something that the longer the clot is sitting there, the theory is that the more likely the valves are going to be damaged. And you're right, do the mechanical methods cause injury to the valves? Maybe. Anyway.
Yeah, thank you. All righty. So
Oh,
any
question.
Yeah.
Sorry. That also makes me think about like when we put stents in the vein, isn't like what's stopping blood from just pooling, and if the valves are not there to close off blood?
No, that's a very good question. So you have to have two things in the vascular beds, arteries or veins, inflow and outflow. So your right atrium, central venous pressure, and when you take a breath in, your intrathoracic pressure decreases, you're driving blood towards the heart. So that's part of it, right? So the outflow is important. The inflow, you're right. So if your tibial veins, your superficial venous system, your perforators aren't driving blood into the deep system, you could get into trouble and thrombose. So you need a combination of decent inflow, right? Some of it's superficial, some of it's perforator, some of it's deep. And sometimes there are duplicated venous systems, and there's a tremendous amount of collateralization that allows the blood to get to the heart. And then the sump of the heart and the right atrial pressure, especially with inhalation, has some impact as well.
So I think specifically to answer your question about the fact that by stenting, you're essentially getting rid of the valves. Like that's your question, right? Yeah, so I think the best way to remember this is that it's a trade-off. So there's multiple ways the blood is getting back to the heart. You got your muscles kind of squeezing and pushing that blood up. You have your valves, and then you have sort of the physiology of when you take a breath in, your pressure in the chest is dropping and blood is driving up towards your heart. So you have three things that are really helping you out here. When you are your muscles are unable to push blood up if you have a clotted DVT. If you have a DVT, you have no flow now. So when you're stenting, yes, you're losing the valves, but you're essentially creating inline flow. You're restoring the flow to the main channel such that while you're losing the valve function, you're still providing, it's a trade-off. Yes, you're losing it, but you're creating one nice vessel to allow blood to go through that column. Does that make sense?
And also one other thing is we tend not to stent infrainguinally in the venous system. So that most of the valves are kind of there in the FEMPOP system, and so the iliac and the cava, where we tend to stent more, don't have it. But what's going to happen is there are going to be other effects. And so you have to be cognizant of that because it's not mimetic. It's not biomimetic, meaning the IVC, the normal IVC in the vein is just more compliant. It goes in and out, whereas the stents are not compliant structures compared to that. So you're right. This is where we need more technology and more of you guys to develop the engineering to enable us to do that. And there's a guy at Daughter Institute who's working on a Pavnich was developing venous valves that could be endovascularly deployed. So these are technologies that we'll need as we move forward.
Yeah. Thank you.
Thank you. All right. Yeah, let's go ahead and dive into the safety outcomes. Let's see, give me a second. So yeah, for the safety outcomes, basically within the first 10 days, major bleeding between intervention versus control. Looking at that, there was higher percentage in the major bleeding within the first 10 days for the intervention. And this was significant as well, but there was no significant difference and major bleeding at 24 months, or any other bleeding or recurrent VTs or death between both groups. All right, and so what were some of the major conclusions drawn by the author, just kind of thinking back to what we've been discussing?
It's not really clear if pharmacomechanical interventions make any real difference in the outcomes, especially with post-thrombotic syndrome versus anticoagulation alone.
Great, yeah. So yeah, PMT, or the pharmacomechanical thrombolysis, did not prevent PTS and acute DVT across groups. And so one of the things that they also looked at was making sure that there was no subpart thrombus removal that would be causing no difference between the two groups, and they did that by venography. And then they also concluded that PMT had a greater amount of early major bleeds over the controls, but overall less bleeds. And there were lower rates of severe PTS and PMT in the PMT group, which may actually should suggest that there are differences in the pathophysiology that, like I said before, lead to the development versus progression of PTS, and that more studies need to be done in that area. So just looking at that, kind of thinking back to everything that we talked about, do you guys agree with that conclusion that the authors drew, and what are some of the things that you would have concluded from looking at the data? And no right or wrong answer.
I think you definitely want to look at the severity of the PTS as well, because if it's there, it doesn't tell you necessarily the grade, and I think that's where the follow-up trial comes in. It's like,
yeah,
maybe so there wasn't a significant difference, but did it affect quality of life, perhaps, if the grade was less severe? So I think that's why people wanted to follow up and see exactly what that looked like.
Yeah, that's great. Yeah, and then we'll definitely dive into that with the next trial. We'll just be covering that very, very briefly. And then what were some of the major limitations that you thought the study had? Both, it could be the things that the authors mentioned, but also things that you think may have taken away from the trial's validity.
So one of the nice things with the ATTRACT trial is we can compare it to the previous trial, right, the CAVENT. And so if we see differences in the outcomes in the patients in both, we start to wonder, is one study maybe not as accurate to the standard population? And so that's something I think Ricardo might cover.
Yeah, and maybe even like the process of lysing the thrombus may have been slightly different in the other trials. So like the length of anticoagulation, if it would, we should probably look at that, or if there are any genetic things that were associated with the people that did develop PTS versus those that didn't develop PTS. And
yeah, that's great.
So I also want to,
yeah, go ahead.
Tushar also mentioned in the chat one of the criticisms, which was that they didn't distinguish between the different methods of mechanical thrombectomy, as in like they didn't randomize between these. And so, this is something, definitely an area of future study, as I think Dr. V alluded to as well, looking at severe PTS between these, these different types of treatments.
Yeah. Yeah, so those are definitely some of the things that actually the authors mentioned in the article as well. And then there were a few others that they mentioned as well. So one of the ones that they talked about was the missing assessment of post-thrombotic syndrome, and that about 2/3 of the 80 that were missed in the entire study were actually in the control group as opposed to the PTS group, which could have underestimated the treatment effect. there was also extensive screening and a lot of exclusion criteria going on, and so this could have decreased the generalizability as well, like we were discussing. And then also, like you guys said, the variation in how the procedures were performed. And even though they tried to standardize these, there's always the intrinsic patient specifics and also physician preferences that go on that could affect the outcome of the procedure. And like Austin mentioned just now, there's no randomization to specific treatment methods, and that's something that is going to have to be studied later on. And one of the things that I myself did not think could have contributed much to, that I didn't think was a great limitation. I don't know if you guys have any opinions on this, but most patients were given warfarin as opposed to direct factor 10A thrombin inhibitors. And so I didn't think that this was a limitation, but that's something that the authors mentioned here. And so does anyone kind of have any thoughts on that as well?
Yeah, I think we definitely need another trial that looks at these thrombin inhibitors and their effect on developing PTS. But yeah, I think that's a big point, another point to notice.
Yeah, great.
I guess it's also something to consider, considering the PTS or the patients, I think, had more major bleeding in the 10 days, right? So yeah, if you're having to bridge to warfarin, maybe that's something to think about. So I don't know, maybe just another factor. Also want to mention that compared to the CAVIT study, the ATTRACT trial did not show the same reduction in PTS. And so, it's possible that the CAVIT over demonstrated how effective the CDT was, or that this study under demonstrated. But there is a difference between these two trials, so they are conflicting, which is interesting.
Yeah, great. So now we're going to go ahead and dive into the secondary analysis of the ATTRACT trial, which we were discussing before. And we'll go through it pretty briefly. So main purpose of the study, so if anyone would, once again, I'm just going to open the floor to anyone that wants to kind of talk about what the main purpose was of the study. And one of the things that they looked at was the iliofemoral DVTs as opposed to the femoral popliteal ones that they stratified the patients in the ATTRACT trial. And so if you could kind of discuss what the clinical implications of studying that specific region was. And you don't have to like go into everything, just if you want to discuss it.
I don't remember. I don't think I went through this one, but was this the one that focused on iliofemoral DVTs because they noticed that? They noticed that there was a difference between iliofemoral versus popliteal femoral, so they wanted to focus on seeing if there was some benefit with this therapy. Yeah. I'm not sure. I don't remember anymore if there was a difference, if they found anything. I don't remember them doing so.
Yeah. Do you remember kind of like why and not to put you on the spot here, like anyone can answer this, but do you remember why they were studying iliofemoral DVT specifically? And Austin kind of alluded to this in his presentation as well.
Yeah, that's where most of our proximal DVTs that lead to PTS are either iliofemoral or cable. Yeah.
Yeah, so basically this study looked at or assessed the benefits and risk of the PCDT in patients in the ATTRACT trial. So they basically pulled the patients that were in the ATTRACT trial who presented with acute iliofemoral DVTs versus other types of DVTs. And so some of the clinical implications that they looked at was basically iliofemoral DVT patients are clinically managed differently from those with just a cath for the femoral popliteal DVT because these patients do have greater recurrence of VTE. They also have more frequent PTS as well and more severe PTS. And then PMCDT may be more beneficial for these patients because the entire volume of the venous blood return goes through that area. And so it can actually increase, the obstruction is worse, and so it can actually increase the venous hypertension and can lead to more severe post-thrombotic morbidity. And so this is something that they really wanted to consider because these patients may actually benefit from this procedure. All right, and some of the results, which I can actually pop over here and anyone can kind of discuss and give their opinions about them, but there's no difference in the occurrence of PTS, but the PMCDT did lead to reduced PTS severity based on VIALTA score and venous clinical severity scores. And then PMCDT also led to a greater reduction in just overall the quality of life measures that they were looking at in the ATTRACT trial, including leg pain, swelling, and also the PMCDT, just like it did in the previous trial, led to greater major bleeding within 10 days. And then the one thing that they found in this one is that there was an increase in recurrent VTs over 24 months as well. And so I know Dr. Warhadpande wanted to kind of discuss just this part of the trial and to basically talk about why there's a different approach to iliofemoral or iliocaval disease versus the other types of diseases, the other types of DVT. So I don't know if Dr. Warhadpande, if you could go into that a little more.
Yep. And Dr. V, feel free to chime in here once I'm done. But so this is the reason I like the ATTRACT trial is because I think this was one of the trials that a lot of interventional radiologists were excited about hearing the results. And when the results actually came out, it was saying that we should not be performing CDT left and right. You know, we should be just anticoagulating him. And I think that was quite disappointing. But the results were the results. You know, that's what the results showed. So we have to respect that. And this was a well put together trial and you know, by a lot of respectable individuals. So the results were essentially saying that we should not be intervening as much as we thought we should. However, there is one particular population that, at least here at UPMC, that we are relatively aggressive with and do perform CDT. And that is the patient, a young patient who has, you know, 30, 40, 50 years ahead of them, who has a iliocaval thrombus. And the reason that we believe that these patients should be treated with CDT is because of exactly the secondary analyses, the secondary outcomes, what they showed, which was that the severity of PTS was decreased in patients who have iliocaval thrombus and get CDT. So that's a really important point, because if that means that we're able to reduce the severity of their chronic problem from having a DVT and maybe improve their life a little bit, they have 30, 40, you know, they have a long life ahead of them, then this is the patient to really consider CDT in. So that is the subpopulation that we focus on. And, you know, one could argue that if you have a patient with end-stage pancreatic cancer who has iliocaval thrombus, well, you know, unfortunately their life expectancy is not great. So we should not be as aggressive with them. So age matters, the life expectancy matters, and then obviously where the clot is matters. So those three things put together really dictate who we now are approaching, at least at UPMC. Dr. V, how do you sort of approach, how
Yeah,
you started using a track trial?
Well, so I think one thing is, you know, we were very kind of cavalier about iliofemoral DVT should lyse, and I think the track trial suggests that maybe it doesn't make as much difference as we thought, you know, in all comers. I do think, so the way I look at it is it a bothersome or life or limb-threatening condition? This is really a bothersome condition. It's exceedingly rare that you're going to lose your limb from venous thrombosis. So venous thrombosis in general is much more benign. Now, it can cause clinical problems, like Dr. Warhadpande was saying. These patients, they're young and active, they get venous claudication, they have heaviness, they have swelling, they get cramping, they have restless legs. So those things are bothersome symptoms that people can really be bothered by. So you have to think about that. Or a very active person, they can't exercise as well because they get venous claudication. So I think in those patients, I agree, you know, because you have to look at three things: safety and efficacy and durability. Is it safe to do the procedure? Well, there's a higher bleeding risk with the catheter-directed thrombolysis, right? So in fact, there, you know, even though the track trial, they didn't have intracranial hemorrhage, it's possible, right? We've seen that with the Optilize, where you did PE lysis. The low dose Optilize trial did have an intracranial bleed. So it's not zero. It's low, but it's not zero with catheter-directed methods. Major hemorrhage is not trivial. If you look at the Seattle 2 trial, 10% risk of major hemorrhage requiring transfusions. So again, and if you look at the Cabin trial, which was the one that was positive, there was a significant major hemorrhage. So again, bleeding is not trivial with TPA or lytic therapy. But I agree that the more proximal the thrombus, the younger the patient, the more active they are, they're lower. The younger the patient, the lower risk of a major bleeding event, especially intracranial bleeding event. Okay, the older patients, based on PITHOS, age over 75, they were higher risk of intracranial events than the age under 75. Subset analysis of the PITHOS trial for looking at IV tenecteplase in PE population. So you can stratify these things to give you a decision tree of what to do, and then ultimately what the patient wants. Now, the other thing is, if the patient's not improving on anticoagulant therapy with a venothromboembolic event, they can't ambulate, they're on IV pain medications, I'm going to be a little bit more aggressive on thrombectomy. The other caveat is in interventional medicine, what we have is a challenge because we're constantly innovating, getting newer devices. And I think I mentioned that we have the CAT-12 and we have the NARI now, where you can almost do this thrombectomy without TPA. So one stage, you don't even have to give lytic, you just anticoagulate. So where does that come into the play? It's a game changer in the sense that maybe we need a trial with that now. So my thought is, if I can do this without lytic, and it's a proximal DVT, like i.e. iliofemoral DVT or iliocable DVT, in a younger patient, I'll at least offer that patient that, especially if their leg swelling is not getting better in 24 to 48 hours on therapeutic anticoagulation, then I'll consider it. The other thing you have to realize is, how soon are you getting a patient therapeutic anticoagulated? If you're just getting heparin to get to therapeutic, it can take a while because they use a factor 10A, they slowly drip it up. When I'm doing something in the lab, I'm bolusing them and I'm checking activated clotting time and then readjusting every 50 minutes. So I get them quickly to therapeutic anticoagulation, to the point that some people advocate Lovenox or low molecular weight heparin because within an hour they're therapeutic, as opposed to guesswork with heparin or Coumadin even. So that's another thing. Are we getting them to the therapeutic levels of anticoagulant therapy in a rapid fashion? So I look at youth, what their desires are, how active were they before or after, extent of clot, and how proximal it is, and what devices do I have to remove the clot. Hope that makes some sense.
Great, thank you. So just the conclusions that they drew from these findings. So PMCDT did not influence the occurrence of PTS or recurrent VT, like we mentioned before, but it did reduce early leg symptoms and over 24 months reduced PTS severity, and then reduced the proportion of patients that developed the moderate to severe PTS and improved their quality of life overall. Oops. So here are some of the references for the articles. So we're just going to go through or into these clinical vignettes. So like I keep saying, there's really no right or wrong answers to this. And Dr. Vatican Chair and Dr. Warhadpande, you guys can definitely chime in on these. But if you guys just want to take a few minutes to kind of read through this one, and if anyone would like to volunteer what they would do with this patient.
Ricardo, I'm going to make one more quick point. And this is an issue that we run into not infrequently, which is the issue with timing. So I think it's important for interventionists to have outreach with the hospital and get the primary care physicians and the hospitalists on board, and to let them know that patients who have, especially young patients who have iliocable thrombus need to be on IR's radar quickly. Routinely, this has definitely happened where patient gets an iliocable clot and the patient kind of just is on the floor for weeks on end, and then they come to us. And then at that point, this is no longer an acute clot. It is a subacute or even sometimes chronic clot, and the options we can provide are limited at that point. So it's important to be able to have a good relationship with hospitalists and make sure that they are aware of what we can provide. And the faster the patient enters our sort of radius, the better options we can provide them. So just another reason to remember that, if you're planning on going into IR, make sure you're able to interface with clinicians well and make sure they are aware of what you can provide.
Thank you for that input. All right. So yeah, if anyone would like to kind of take a few minutes to go through this and would want to volunteer.
I can start off, and then someone can
Yeah, go ahead.
help. Well, so looking at the patient, I think we should look at doing a well score to determine if they are higher risk. It looks like they're high risk, and then we'll probably do a D-dimer or an ultrasound, compressible ultrasound. And then the ultrasound shows us, yes, that there's a thrombus. Okay, so now it's in the posterior tibial vein. This seems like it's more distal, and I don't think CDT would be indicated in this patient, but I would put them on an anticoagulant. And what else should I do?
Yeah, that's it. I mean, I thought that was a great answer. So I don't know if Dr. Vatican Chair or Dr. Warhadpande can kind of talk about this case really quickly if you read it, or if you agree.
Honestly, I wouldn't even do anticoagulation. If it's a distal DVT, I would just monitor if you feel like you can get a repeat ultrasound to make sure it's not extending upwards. But I really wouldn't do any treatment.
Great.
I mean, I probably would put her on anticoagulant therapy because it's a popliteal vein clot. But I would think that this, I wouldn't do any CDT. He's got a pancreatitis. Look at the CTA, make sure. The caveat is sometimes these have splenic vein thrombosis, sometimes they have pseudoaneurysm, sometimes they have hemorrhagic pancreatitis. So you have to weigh that into your consideration of anticoagulant or not. So if you have mesenteric venous thrombosis, may anticoagulate. If they have a pseudo-A or hemorrhagic pancreatitis, I may be weary of it. Or if the hemoglobin's dropping, I would be weary of it and may even, but I do, I would, in general, popliteal vein clot, I'll treat. And I'll probably do a 3-month course of anticoagulant therapy.
Great. All righty. So this one's a little different. And you can go ahead and take a few minutes to read that one as well. Anyone have any ideas as to what they would want to do with this patient?
I think anticoagulation to start with, certainly because of the clot, but also because he's got a reason to have the clot because he's been sedentary and also because he has stage 3 colon cancer. And because it's so proximal, that would be a good indication to do pharmacomechanical therapy, unless the extent of the colon cancer was such that you didn't think it was worth the risk or if it wouldn't necessarily be of any benefit long-term.
Yeah. And
Although I don't know why you would suspect that it might be extending into the contralateral common iliac vein.
Yeah. So I guess one of the things that I put in the vignette here, and some of the things that they have mentioned in previous trials, and is basically one of the things that you look for is the erythema that kind of starts developing in the other leg. And so that's what I was alluding to in this as well. But I know Dr. Warhadpande was also talking about just basically patients with metastatic cancers that are older. So what would you do in this patient, not to put you on the spot or anything?
Hello. Hey. So this patient I would treat with Lovenox. I think this is a very clear-cut case. I don't think I would be very aggressive with CDT, but I definitely would treat with Lovenox.
Yeah, I mean, I think that's very reasonable based on the clot trial. Lovenox is the preferred agent. If not, based on Adam and Cavarajjo, which are more recent trials, apixabans are very reasonable in the cancer population. Now, having said that, you got to be careful about GI malignancies in apixaban because the bleeding rate's higher. So if he has not been treated, unresected colon cancer, then you have to be careful of apixaban in the population from a bleeding standpoint. So then Lovenox would be preferred from that standpoint. So GI malignancies and apixaban is where these the 10A agents are where you have to be a little bit more careful. But I think that's reasonable. But this patient has CFV clot, so you know he probably has iliofemoral clot. You always have to look up higher. Good. But if he doesn't get better, he's progressing, then I would consider a pure mechanical thrombectomy with either Lovenox on board or perhaps apixaban. Now realize he has stage 3 colon cancer. If he has stage 4 even, and he has colon liver metastases that can be resectable, his 5-year 50% survival he has over 5-year 50% survival. So they tend to do well with the curative intent resection. So don't blow up the colon cancers. And then the first line and second line chemotherapy agents, FOLFOX, FOLFIRI, and Avastin, and their KRAS wild type or Erbitux, they do substantially well as far as prolonging survival. So the first and second line therapeutic options are not trivial for that population, even with unresectable colon cancer. And if you look at a clock trial, with ablative therapy, they can actually expand it even further. So, recognize that when you're looking at the type of tumor, what has been done, and they're all different.
Great, thank you so much. All righty. Does anyone have any questions on any of these two cases?
I want to make a quick point about the first case. So as you probably noticed, there's a lot of debate about which types of
Sorry, I think you may be cutting up a little bit. I don't know if anyone could hear him. I can't on my end. Yeah, Dr. Warhadpande, I think you may be cutting a little bit. Oh, may have lost him. All right, he can probably chime in after once he's able to get back in. Is he on there? Austin, do you see him on there or?
I see him on. Yeah, because this might be a problem for the Q&A. So we'll figure it out if it comes to that.
Okay. All right. So if no one has any questions, I'm going to go ahead and just kind of open the floor for any questions that you may have for our faculty advisors today.
Yeah. So to quickly introduce again, Dr. Warhadpande is a PGY5 ESIR resident at Pitt. He'll be doing his fellowship next year at MCW, and he's the lead author of the Pocketbook of Clinical IR, which is an excellent resource for medical students, especially before your sub-internships. Dr. Vatican Cherry, fortunately, is also with us today, and he's the program director of the IR residency at Kaiser LA Medical Center.
Austin, Ricardo, are you able to hear me now?
Yeah.
Sorry about that.
Yeah, I'll do it.
I had a question about access when you have these thromboses. Are you going retrograde or anterograde? Does it depend on the location, or is it always the same direction whenever you're accessing these clots?
Great. That's a great question. So you can have multiple accesses. So if I'm doing, depending on where the distal end of the clot is, all right, and what device I'm using. So if I'm doing thrombolytic, I may access the posterior tibial or anterior tibial veins at the level of the ankle or the foot and drip some lytic there. And then if the clot is above the common femoral vein, I'll access the CFV and do the common femoral vein and do the work there. Sometimes I'll even access the jugular vein. Many times I'll access the popliteal vein in the back of the knee, or even the short saphenous vein or the greater saphenous vein. So the axis, I've used all of these accesses, and it can be quite variable. but great question.
Yeah, routinely you'll see, especially for May-Thurner patients, you'll routinely see popliteal access, and that's something that it's sort of a unique access, especially when I was a med student. It was fun to watch sort of a non-traditional access, but a lot of the bigger cases, you'll get multiple accesses just to provide more access points to get more tools in if you need to. But yeah, May-Thurner is definitely one of the cases that I've seen the most popliteal accesses in.
Thank you. All right.
I have a question.
Yeah, go ahead.
I'm sorry to cut you off. In considering IVC filters for some of these more proximal thromboses, how far, and we talked about caval thromboses, how far up the IVC would you be willing to consider placing a filter if you had, how proximal is too proximal for placing an IVC filter before you, run into risk of getting too close to the right atrium?
Great question. Go ahead.
Yeah, Dr. V, you can definitely correct me if I'm wrong here, but my understanding is that the goal of these pre-procedure filters is to essentially catch any clot from going into to causing a PE, right? So when we place an IVC filter for what we so-called routine reasons, failure of anticoagulation and so on, we place it by the renals. So the whole point of that is to make sure, because it's going to be in there for a longer period of time, we want to consider we don't want to cause any renal vein thrombosis or something like that. But for when we're placing an IVC filter just for the procedure for several hours at max, then I think we can be a little bit more aggressive with where we place it. So we can place it high. So the one that I've seen was very close to the hepatic vein. So, I mean, very, very close to the right atrium. So the whole point is just to prevent a PE, and then you're going to take it right out. So what do you do, Dr. V?
Yeah, no, I mean, in general, like if we have a patient who can't be anticoagulated, has venothromboembolic disease, infrarenal filter placement. Peri-procedurally, we can either leave it on the wire as we do the intervention or on the sheath. So it's just a protective mechanism while we're doing the declot to prevent a major PE. Others have actually used a wall stent and partially deployed it, like a 24-millimeter wall stent, and just partially deployed it to ask as a basket, but maintain forward flow. So yeah, it's just a transient thing to prevent major pulmonary embolus, but you should always be ready to chase a PE in case you get into big trouble. And then you can put it up, in the kind of the periatrial area. But in general, I try to avoid that for long term, because if you're above the renal veins clot, now you have renal vein thrombosis. You're at the hepatic veins, it can embed into the IVC, it can fly and migrate to the heart because it's not well embedded at that area. It's a lot of compliance changes, or it can thrombose the veins. So you just have to be cognizant of that. So in general, I prefer infrarenal filter placement. And if I'm going to do a filter higher, it's usually like Dr. Warhadpande said, in a transient fashion, where I'm going to pull it as soon as I get the clot out.
Thank you.
Thank you. All right.
I had a question for Dr. Warhadpande. How was your experience writing the Pocketbook in residency, and how did you try to balance your learning opportunity or learning responsibilities with the writing responsibilities?
Is he on? We may not be able to hear him now, I don't think.
Warhadpande is a pretty motivated individual.
Oh no.
Are you guys able to hear me?
Yeah, a little bit.
All right. Question in about 5 minutes. I just parked in the hospital, so I'm gonna walking over. So give me a couple minutes.
Sounds good.
So Warhadpande was also the head of the RFS, the governing council. So he had a lot on his plate, but he's a highly motivated individual, kind of the future kind of the current class of interventionalists are very motivated trainees coming up, and they can really balance a lot of things on their plate. So that's what I'm seeing with this current generation. So he was he wanted to be a clinician. He was going the surgical route, and realized that the IR can offer him that. So again, this is just a new age of interventional, and this is what many of you are capable of doing. But he is definitely an exemplary trainee and accomplished all this in a short amount of time.
Sorry, does anyone else have questions? Sorry.
No, go ahead.
For a question for Dr. V. So for the more junior medical students in the audience, what do you recommend in terms of getting exposure to IR and getting more involved in the national community?
Yeah, number one is I think I would identify like some mentors. Get involved in the Med Student Council. Okay, get on the reserves or get on the MSc. Get to start a VIRAC, a vascular interventional radiology interest group if you can. And if you don't have a local one, try to identify. There's so many options around the country. Any of us, me or Dr. Warhadpande, are more than happy to mentor people to get them on the road, or identify local interventionalists that they can shadow and learn from, get involved in some research projects early on with them. And again, nowadays you can do a lot of this case reports. I know I've worked with Austin on some research remotely, so it's very feasible. So these are things that can be done, without question. But definitely get involved in the Med Student Council. Start up a vascular interventional radiology interest group if you don't have one. Go to as many of these kind of virtual webinars such as this, and the ones that there's one at Brown this weekend that I encourage you to try to attend, a Brown Symposium. There's going to have a lot of speakers. Any of these virtual symposiums are very important.
Hey y'all, can you hear me now? I apologize. I'm walking around the hospital, so I might have some bad connection.
Yeah, we can hear you.
Yeah, we hear
Perfect.
you.
I apologize. Sorry about that. Well, I didn't catch the question that was asked. I heard part of it. Something about.
Yeah, I was just asking how you balanced writing the pocketbook and coordinating all of that, and then also your educational responsibilities as a resident.
Got it. So I think a lot of these projects that the RFS works on, and this is not just me, but pretty much anyone in the RFS or for MSc even, it's just a juggling. You gotta get good at juggling. My wife definitely was not very happy with me that year, but she understood. This is something that I'm very passionate about. So it never felt like work. So it honestly it was something that I wanted to do, and a lot of my free time was spent doing it, and it never really felt like work. So even though I was coming home at whatever time from my surgical intern year, I would still kind of work on it throughout the night. So yeah, I think you guys are all kind of looking into IR now. You'll find that when you're truly very, very passionate about the specialty or whatever you're interested in, when you start working on projects and whatnot, it never feels like work. It feels like you're taking sort of the next step in the evolution of the specialty. So, that's I think one of the reasons why the MSc and RFS have done such a good job is because sort of the people involved aren't involved because they want to add on their CV. They're doing it because they truly love the specialty and believe where it's headed, which is in a more clinical direction. So, this is a great first step. This entire journal club, I think, is a great idea. And, I'm learning from it too. I'm still a trainee. I'm a fifth year, so I have a lot of learning still to do. So I learned from this too. So it's a fantastic idea. And please let me know if you want to get involved, either in the RFS or in any other way. Please reach out to me. Ricardo, if you want to just share my cell phone number with them, please text me, call me anytime.
Will do. All right. So if no one has any questions, just wanted to first thank Dr. Warhadpande and Dr. Vedantham for being here today, and also Austin for inviting me to co-host the first one. And I hope there are many more to come, and I think this will be a lot of fun in the next year or so.
Yes, I just want to thank everyone so much for participating in this inaugural session. Obviously, there's some bumps. in the road, but we'll work these kinks out as we go along. But most importantly, this is such a great educational opportunity and so unique to get all these minds together who are passionate about IR across the country. The next one will be hosted next month in October by 2 different schools. And so, we'll really get a wide variety of perspectives as this keeps going on. So bear with us. But yeah, thank you again so much for joining us.
Thank you.
All right, that concludes it. Thanks, everyone.
See you tomorrow.
For hard work.
Thank you.